Good afternoon. Thank you to everyone for joining us today. I hope that you and your loved ones are well during these very strange and unprecedented times. My name is Rosemary Morgan. I'm a breast surgical oncology fellow at Cedars-Sinai Medical Center. I graduated from the University of Colorado School of Medicine after I completed my undergraduate degree at Stanford. I did my residency in general surgery at Oregon Health and Science University in Portland, Oregon. I now have just 2 more months in my fellowship at Cedars-Sinai. My fellowship in breast surgical oncology has focused not only on mastering the latest surgical techniques for treating breast cancer, but also on how to promote the general well-being of patients before and after their operation for breast cancer. So it's a pleasure to be here today, and I thank you for having me. Please feel free to ask questions at any point during the presentation. I cannot see or hear you, but you can use the Q&A feature to submit a question, and I will do my best to answer as we go along. So at some point in every woman's life, her ovaries stop producing eggs, and the levels of the hormones estrogen and progesterone start to go down. Over time, what used to be a monthly period becomes less and less frequent. This process and time of transition is what we refer to when we discuss perimenopause. When you've stopped menstruating for 1 full and complete year, you are then said to be officially postmenopausal. Most women go through menopause as just another part of the natural aging process. American women enter menopause at the average age of 51, and they then live a full 1/3 of their lives after menopause. So there are 40 million American women today who are postmenopausal, and another 20 million will enter menopause in the next decade. With all of our advances in how we diagnose and treat breast cancer survivors make up a significant proportion of these women. Of course, there's variation in the age at which you enter menopause. For some women, it's sooner than 51, and for some later. But for women who've been diagnosed with breast cancer before menopause, some of the treatments they need can bring on menopause more quickly and more abruptly than they expected. Treatment for breast cancer can also increase the severity of menopausal symptoms. But there are ways to manage symptoms and live more comfortably with menopause. Today, we'll discuss ways to manage menopausal symptoms in breast cancer patients. So in the United States, women have a 1 in 8 lifetime risk of getting breast cancer. It means more than 240,000 women are diagnosed every year. And approximately 25% of those women are premenopausal at the time of their breast cancer diagnosis. Many of these women will lose ovarian function and thus will enter menopause earlier than they would have otherwise. In most cases in which women enter menopause early with breast cancer, that's usually associated with them receiving chemotherapy. When we look at the women who are diagnosed with breast cancer when they're between 40 and 49 years old, only 30% of those women start having a period again after standard chemotherapy. So why can some breast cancer treatments bring on menopause or menopause symptoms more quickly or abruptly than you expected? There are actually several reasons why this can happen. As I just mentioned, certain chemotherapies, along with hormonal therapies, can make the ovaries slow down or stop functioning. This is called medical menopause, and it can be temporary. So that is, it can last while you're in treatment and for some time afterwards, but then your periods can return. On the other hand, it may be permanent. Removal of the ovaries, which is recommended for some women, causes immediate permanent menopause. We call this surgical menopause. Some other therapies, like hormone therapy with Tamoxifen or aromatase inhibitors or ovarian suppression, don't actually lead to menopause, but instead cause symptoms of menopause, such as hot flashes. These can affect you if you're premenopausal at diagnosis, or if you've already started menopause naturally, you may find that your menopause symptoms get worse. And finally, there's also what's called cold turkey menopause, a result of stopping hormone replacement therapy, which some women use to treat natural menopause symptoms that were already severe or bothersome to begin with. Medical, surgical, and cold turkey menopause all cause sudden and dramatic shifts within the body. Hormone levels are lowered within days or weeks instead of over years, and symptoms can come on more abruptly than they would with a more gradual natural menopause. Given that the average age for natural menopause is 51, many women find that they're perimenopausal or postmenopausal just as they receive a breast cancer diagnosis. And if this is true for you, it may be hard to tell the difference between natural menopausal symptoms and those that are triggered by breast cancer treatments. Also, if you've recently stopped using hormone replacement therapy because of a breast cancer diagnosis, this can complicate matters even more. If you're much younger than 50, you'll probably know that your treatment is what's causing you to feel like you're in menopause. But it can still be hard to tell if this menopause is temporary or permanent. The closer you are to age 50, the more likely it is that you'll be in menopause for good. In the midst and then even in the aftermath of treatment for breast cancer, it can be difficult to tell whether you've gone into menopause for good. For example, maybe your periods stopped during chemotherapy, but still haven't returned a few months after finishing treatment. The younger you are, the better the odds are that they will return. Knowing for sure whether or not you're permanently in menopause can matter to you because you still may want to have biological children. You may be curious about where you stand and want to know what to expect. Also, your doctor may want to know your menopausal status to help determine the best treatment options for you. So we use 2 blood tests to help us determine whether you're in menopause or not. The first is follicle stimulating hormone, or FSH. FSH is made by the brain to stimulate ovulation. If your ovaries are beyond menopause, they no longer respond to FSH, and your brain reacts by sending out even more of this hormone. If your periods have stopped for some time, a persistently high level of FSH indicates that menopause may be permanent. But still, tracking your results over time is important because these levels can swing widely from day to day. For example, in a normal menopausal woman, it's not unusual for her FSH level to be low one day and then quite high the next. So the other tests we look at are your estradiol levels. Estradiol is the main form of estrogen that's found in premenopausal women. A normal level is 300 to 400, but after menopause, it falls below 300. It is important to note that if you're taking Tamoxifen, which again is a hormone therapy for breast cancer, this test result, your estradiol levels, may not give you an accurate picture of your status. It's also important to remember that these blood tests are not the final answer to whether or not you're in menopause. So even if you have postmenopausal levels of both FSH and estradiol, these levels can change over time. But the longer you go without a period and the longer the repeat testing suggests that you are menopausal, the more likely it is that you are in this stage of life for good. You may encounter some other menopause tests that you can do at home on your own using urine or saliva, but these tests are not considered reliable. So if you're interested in testing, it's something to be sure to discuss with your doctor. The symptoms of menopause and their severity can vary widely from woman to woman. Every woman thinks about menopause a little bit differently too. Some are eager for the end of monthly periods and are happy to never worry about birth control again. Others experience a sense of loss over no longer being fertile, and some associate menopause with feeling less youthful. Some younger women also say that they find it difficult to think of themselves as menopausal when it happens as a result of breast cancer treatments instead of with the course of natural aging. If you're already going through menopause, dealing with a breast cancer diagnosis on top of that can be challenging in its own right. You're raising children, taking care of aging parents, tending to a spouse, a job, a social life, and other obligations that can already leave you feeling maxed out. And then feeling like you're not yourself because of menopausal symptoms and breast cancer treatment side effects is enough to stretch anyone to the limit. As women approach menopause, whether it's natural or they're pushed into it by breast cancer treatments, most women are kind of first concerned about the more in-your-face symptoms, like hot flashes, weight gain, vaginal dryness, mood changes, and fatigue. But over the longer term, you may come to think more about osteoporosis and cardiovascular disease. So when you think of menopausal symptoms, the first thing that comes to mind for most of us is the hot flash. Hot flashes occur in about 75% of all menopausal women, so it's not universal. A hot flash is a sudden, intense, hot feeling on your face and upper body that can be preceded or accompanied by a rapid heartbeat and sweating, nausea, dizziness, anxiety, headache, or weakness. Some women get an aura or like this uneasy feeling just before the hot flash that lets them know it's coming. And then that flash, that feeling, is followed by a flush, which leaves you red and sweating. Again, every woman's experience is a little bit different. The faster that you transition from regular periods to no periods, the more significant your hot flashes can be. Hot flashes are caused by hormonal changes in an area of the brain called the hypothalamus. The hypothalamus has many functions, one of which is thermoregulation, or serving as your body's thermostat. Changes in your hormones cause levels of the neurotransmitters to confuse the hypothalamus, which cause the hypothalamus to suddenly read the body temperature as too hot and adjust the set point for the thermostat. So even though your body temperature hasn't actually changed, your brain sends out a signal that says it's too hot and tells your body to adjust by increasing your heart rate, dilating the blood vessels in your skin to circulate more blood and radiate off the heat. And then you release sweat from your sweat glands to cool you off even more. A hot flash typically lasts 30 seconds to several minutes, but again, the frequency and severity can vary substantially. Some women report mild discomfort that doesn't really disturb them, and others just feel that they are nearly incapacitated. It's important to note that Tamoxifen, which again is an anti-estrogen hormonal therapy, it's used for treating some forms of breast cancer. Tamoxifen causes hot flashes in over 50% of women who take it. Typically, the hot flashes get worse over the first several months of treatment, but then they do get better, becoming less frequent and less severe as your body becomes used to that lower estrogen state, just as you do over time with natural menopause. In all menopausal women, hot flashes and night sweats are associated with poor quality sleep and increased fatigue. Unfortunately, when breast cancer survivors are compared to women of the same age who have not had breast cancer, hot flashes have been found to be more frequent, more severe, and more persistent in the breast cancer survivors. Natural menopause causes changes also in the tissue of the vulva and vagina. And with natural menopause, that usually occurs over a period of 3 to 5 years. But that can occur over a shorter period of time, even just several months of starting breast cancer treatment. So as your estrogen levels decline, the vulva loses most of its stretchy collagen, its cushioning fat tissue, and its water retaining ability. This causes the vulva to become flattened and thin. The vagina shortens and narrows as well. And the vaginal walls become thinner, less elastic, more easily irritated, and also less able to produce lubricating secretions during intercourse. The acid-base balance of the vagina also changes, which can lead to more frequent infections in the area, like yeast infections and urinary tract infections. And for those who need to take an anti-estrogen therapy as part of their breast cancer treatment, it's interesting to know, so those kind of come in two flavors. It's interesting that the aromatase inhibitors are associated with a high rate of these vulvovaginal symptoms, but tamoxifen can have pro-estrogen effects on the vagina and can actually be associated with fewer of these complaints. Most American adults experience slow but steady weight gain beginning in their 30s, 40s, and 50s. As women enter their 40s and 50s, their metabolic rate slows, so unfortunately, fewer calories are needed to maintain the same weight. And if no changes are made, the result for all of us is weight gain. Menopause then itself is associated with an increase in total body fat, as well as redistribution of fat to the abdominal area. This happens with natural menopause, as well as the menopause associated with breast cancer treatment. Chemotherapy is also frequently associated with the use of steroid medications, which can cause weight gain. Chemotherapy, other breast cancer treatments can also make it hard to stay physically active and stick to a healthy diet. On top of all this, the lower hormone levels of menopause decrease your body's muscle mass, Muscle burns more calories than fat, so this further decreases your body's need for calories. And if your body's getting more calories than it can burn, weight gain is the result. With any major transition in our lives, there's a potential for feelings of grief. And by grief, I mean a feeling of deep sadness and loss. We frequently think of grief as a feeling experienced after the loss of a loved one, but grief is a feeling that we can have for loss in many other ways. Grief can come with major life transitions, and both menopause and breast cancer count as major life transitions. So experiencing grief while dealing with your breast cancer is very normal. But talking to your doctors about your mood and monitoring for depression is important because up to 50% of patients experience depression in the first year after a breast cancer diagnosis. Risk factors for experiencing depression after a breast cancer diagnosis include having a particularly difficult time coping with a cancer diagnosis, difficulty tolerating the cancer treatments, having other work and family issues also at play, and also a prior history of depression before the cancer diagnosis. Transitioning into menopause can also contribute to these mood symptoms as well. Hot flashes and night sweats can cause sleep problems, and research shows that the role of sleep disturbance in experiencing psychological distress is significant. The disturbance in sleep with menopause, however, does not appear to fully explain the effect on menopause, the effect on mood all by itself. There's more and more evidence to show us that bone health is a particularly long-term concern for women with breast cancer. So your bones are living tissues that constantly rebuild themselves over the course of your life. During your childhood and teenage years, your body adds new bone faster than it gets rid of old bone. But after about the age 30, you can start to lose bone faster than your body makes it, which can weaken your bones and increase the risk of breakage or fracture. This becomes more critical after menopause. So when you go through menopause, your levels of estrogen and other hormones drop sharply. Because estrogen helps maintain bone density, this drop can lead to significant bone loss. Fortunately, this doesn't happen overnight, but over time, women are at risk of developing low bone density. We categorize low bone density in two ways. Osteopenia means that you have bone density which is lower than normal. Osteoporosis means that you have lower bone density than people with osteopenia, and that your bone density is now at a level where your bones are brittle and can break easily. The Women's Health Initiative is a very famous long-term national health study that tried to find, the purpose of the study was to try to find strategies for preventing heart disease, breast and colon cancer, and osteoporotic fractures in postmenopausal women. In this study, they found that women with breast cancer had a 31% higher risk of having fractures than women who did not have breast cancer. So estrogen helps prevent your body from breaking down your bones faster than it builds them. So menopause can lead to significant bone loss all by itself. And as we have discussed, breast cancer treatments further reduce your estrogen levels and leave you at even higher risk of bone loss and osteopenia or osteoporosis. While many people know that 1 in 8 women get breast cancer, it's much less commonly known, much less commonly discussed, that 1 out of every 3 women gets heart disease. So compared to men, women develop heart and blood vessel disease later in life. Men in their 30s and 40s have much higher rates of heart and blood vessel disease than women in their 30s and 40s. But by the time men and women are in their 80s, there's no gender difference. They have the same rates of cardiovascular disease. This delay in the development of cardiovascular disease in women is thought to be thanks to the effects of estrogen before menopause. So estrogen is good for your cholesterol, the tone of your blood vessels, and clotting factors. And when you go into menopause, whether that menopause is the result of aging or is due to breast cancer treatments, you develop a higher risk of cardiovascular disease. Certain treatments for breast cancer also increase the risk of heart disease. Some chemotherapies, such as adriamycin and Herceptin, can directly damage the heart. We monitor for that very closely. We also used to worry about radiation therapy damaging the heart, but the risk of that, having heart damage from radiation, is now much less than it was previously. So I've enumerated this long list of menopausal symptoms, and I've shown how they largely arise from the decline in estrogen associated with menopause. And I've tried to explain how that can be made worse by breast cancer treatments. So if lack of estrogen is the problem, a reasonable question would be, can you just take estrogen for relief? There have been countless studies that have looked at the potential risks and benefits of hormone replacement therapy, which typically provides estrogen plus minus progesterone. And these studies particularly have tried to examine the increased risk of breast cancer. But it's very hard to compare their results and make sense of them all together because these studies often differ in key ways. So for example, many of the studies differ in the type of estrogen and progesterone used, the length of time that HRT is used, the dose of the hormones that are used, the age at which women in the studies started taking HRT, and there's many differences in the underlying health of the participants in these studies. So for doctors, piecing it all together is like taking puzzle pieces from different boxes and trying to put them into a picture that makes sense. News reports about HRT usually report on the conclusions of the latest study rather than comprehensively reviewing the body of research as a whole. And I think that can make things even more confusing. So like I said, this is a controversial and complex topic, but for now, hormone replacement therapy is not recommended for women with a history of breast cancer or for women who have higher than average risk of developing breast cancer. Because we know that hormones can fuel breast cancer growth, there have not been a large number of trials examining hormone replacement therapy in women who have a previous breast cancer diagnosis. Many researchers have simply felt that it's too unsafe to try to do this with, in an experimental manner. The largest trial that has been performed was called the Hormonal Therapy After Breast Cancer, Is It Safe trial, or HABITS trial. In this trial, researchers recruited women who had breast cancer and had menopausal symptoms that were severe enough to require treatment. They then randomly assigned the women to either 2 years of hormone replacement therapy or 2 years of non-hormonal treatments. They then looked to see how many of these women developed new breast cancers or had their breast cancer come back. They enrolled 345 women and followed them for 2 years. And they were planning to enroll more women than that in the trial to continue it for a longer period of time. But when they were at this stage, they ran a safety analysis, which is required for research trials, and they found that there were 26 breast cancers in the group of women receiving HRT compared to only 7 in the group of women who were getting non-hormonal treatments. Because there were so many more breast cancers in the group of women receiving hormone replacement therapy, the study was ended early. And this is the primary study that people point to when they say that that research shows that it appears that hormone replacement therapy is not safe in women who have had breast cancer. Let's see, we have a question. So the question is, do hot flashes diminish while taking Arimidex? And what are remedies for vaginal symptoms? So great question. So yes, similarly with Arimidex, hot flashes can be quite intense at the beginning and can increase for the first few months while you're taking Arimidex, but over time, they do get better. And then what are remedies for vaginal symptoms? That's a great question. I think hot flashes are usually the first thing people ask about, but what to do for vaginal symptoms is kind of the second most frequent, most bothersome complaint. And I will go over a couple in just a moment. But let's see, so if estrogen is not an option, a good question then is, what are effective treatment strategies? So I'll take a look at some different treatment options based on symptoms. Another question excellent question, is progesterone replacement therapy useful and or safe if you are PR negative? The answer to that is the research indicates no. Typically hormone replacement therapy, all hormone replacement therapy provides estrogen replacement. And then progesterone is interestingly only needed if a woman still has a uterus. So if a woman has had a hysterectomy, estrogen therapy alone is provided and seems to be somewhat lower risk than the combination estrogen and progesterone therapy. But providing any form of hormone replacement therapy, the risk profile doesn't seem to change based on the hormone receptor profile of your breast cancer. So even women who have triple negative breast cancer, where they're both estrogen and progesterone receptor negative, hormone replacement therapy is, at this point in time, not provided to those women. So it's a great question. Thank you. And then another question. Thank you guys for the involvement, participation. So for a patient on an aromatase inhibitor, will vaginal symptoms of pain and burning with intercourse get better or worse with time? That's a good question. Let me come back to that one. I'll save that question. And when we kind of go over some of the treatments, let me make sure that I've answered that satisfactorily. Let's see. Okay. So I'm going to talk about hot flashes, and then I'll talk about treatment for the vaginal symptoms. So we said that 75% of women who go through menopause get hot flashes. And for most women, these hot flashes last for 1 to 2 years after their periods stop and then go away. But unfortunately, for somewhere between 20 and 50% of women, those hot flashes last longer than that. Most women say that their hot flashes are mild to moderate. Overall, 10 to 15% of women seek medical treatment for severe hot flashes. So I always recommend starting simply without medications if possible. And there can be many triggers for hot flashes, which again can vary from woman to woman. So some people have found that it's helpful to keep a log of what seemed to trigger their hot flashes to help identify patterns. One trigger that seems to top the charts for many women is stress. So they're rushing to an appointment or they have a critical meeting at work, and just when it seems least ideal, a terrible hot flash comes on. You can't cut stress out of your life completely, but if you know that stress is a trigger for you, you can try to do things like add an extra time to get to an appointment or keep your work schedule open in the morning with a break before that critical meeting to avoid this trigger, particularly when it would be at the least opportune time to have a hot flash. Other common hot flash triggers include alcohol and caffeine, hot food, that's hot food both in terms of temperature and spiciness, hot weather, a warm room or bedroom, hot tubs, hot showers, saunas, and interestingly, smoking. So if these trigger hot flashes for you, try cutting them out of your life or avoiding them when a hot flash would be most unwelcome. Lifestyle changes such as exercise and balanced nutrition can also help lessen the severity and frequency of your hot flashes. For exercise, I recommend making simple changes like taking the stairs instead of the elevator or adding in an evening walk. Patients frequently ask about what level of exertion they should be targeting for exercise while they're undergoing breast cancer treatment. And so a good rule of thumb that I like is called the sing-talk test. So when you're making changes to increase your level of activity, you should be pushing your body hard enough that it would be uncomfortable to sing, but you should still be able to talk to someone working out with you in a comfortable way. So I know that CSCLA has amazing resources to help with changing your diet, which can help with boosting your energy, managing your weight, and controlling your hot flashes. Some very simple rules of thumb are to stick to small, light, regular meals with fewer calories, minimal fat, and more vegetables and fruit. Also, CSCLA has great resources for stress reduction. Reducing stress and learning how to relax can be helpful in reducing the frequency and intensity of hot flashes. Some examples of strategies that you can learn include relaxation exercises, breathing exercises, meditation, visualization, yoga, massage can be helpful, and even hypnosis, although that treatment is a little bit more difficult for most people to access. There's some research suggesting that mindfulness training in particular can help improve quality of life for women who are bothered by hot flashes and night sweats. Interestingly, I think the research shows that it won't necessarily, even the mindfulness training doesn't reduce the severity or the frequency of hot flashes, but participants in these studies say that it makes them seem less bothersome. So mindfulness training helps you become more aware of the present moment without focusing on the past or future, and help you to create a space where you can't focus on past negative events or worry about what might happen in the future. And you can learn mindfulness on your own. You can use a CD. There's lots of podcasts or apps, or you can do it by participating in training sessions with an instructor. But if you do try diet, exercise, and some of these other strategies for controlling hot flashes and nothing seems to help, there are a variety of medications that can provide treatment. So the medications that we use to treat hot flashes were, interestingly, all medications initially developed to treat other conditions. They generally fall into these three categories. So number one, medications for treating depression, then medications for treating nerve pain, and then medications that were designed to lower blood pressure. So in the 1990s, people just happened to notice, they had these anecdotal reports, that menopausal women who were taking two kinds of antidepressants that were available at that time noticed that their hot flashes were significantly better after starting these medications. There were then 4 key trials that were performed to further examine the risks and benefits of using these medications just to treat hot flashes. And I've listed the 4 antidepressants here that are most frequently used to treat hot flashes. All are used in low doses, and the clinical trials have shown that they lead to a 50 to 60% reduction in hot flashes. With my patients, I personally have found that venlafaxine, which is known as the brand name Effexor, seems to be extremely helpful. The only thing to note about Effexor is that it does require some careful tapering. So when you stop taking it, that needs to be done gradually with your physician stepping down the dose over time. And then I'll also point out that paroxetine or Paxil can't be taken if you're using tamoxifen, because Paxil and tamoxifen interact, so that Paxil makes tamoxifen less effective. The next class of medications, those that are used for nerve pain, include Gabapentin and Pregabalin. In a randomized trial that compared these 2 medications directly to each other, it was found that they were equally effective in treating hot flashes, but patients seemed to prefer the Pregabalin or Lyrica to the Gabapentin. It seems that a lot of this preference came from the fact that Gabapentin makes people feel pretty sleepy. Some people report that, not everyone, but many people do report that it makes them sleepy. So if you have hot flashes that bother you primarily as night sweats, this side effect can actually be put to good use. And Gabapentin can be particularly helpful for women who really just have nighttime symptoms. To be honest, I do not usually venture outside of using those first 2 categories of medications, but I included the category of medication that was originally designed to treat blood pressure because some women who need to treat high blood pressure and have hot flashes are interested in taking just one medication to control both issues. The medication in this class that has been studied the most is clonidine or Catapres. This medication is not as effective as the other 2 categories, and it has more side effects. So for most people, they'll experience some degree of dry mouth. Some people also report insomnia, constipation, and drowsiness. So with that side effect profile and it being less effective, you can see why we don't use it as much as the others. And let's see, so I have a question. Someone said that green tea helped them with the hot flash. Does it work? That is very interesting. Frequently, people will say that hot drinks, like hot tea or caffeine, will actually make them, that can be a trigger for a hot flash. But obviously, you're pointing out that there's not kind of a universal experience. So green tea, hot beverages would not be a trigger for everyone. And if it helped with hot flushes for you, that's great. Green tea, some people think, has some other health benefits. So that's something I've never heard before, but again, is nice to know that that worked for you. All right, so I think we had a couple questions about the vulvovaginal changes that come with menopause and breast cancer treatment. And for symptom relief, there are a few options. So continued sexual activity increases blood flow to the area and is thought to actually help maintain vaginal tissues. And water-based lubricants safely decrease discomfort during intercourse, and they're applied and reapplied as needed to reduce friction and discomfort during intercourse. Vaginal moisturizers are applied directly to the vagina several times a week as a regular practice, regardless of whether or not you plan to have intercourse. These moisturizers bind to the cells in the vagina and help the cells mature. They also restore the regular acid-base balance of the vagina, which can help with yeast infections and urinary tract infections. And in one randomized trial, vaginal moisturizers were equally effective to vaginal estrogens, which we'll talk about next. These lubricants and moisturizers are available in pharmacies over the counter, but if they're not effective, you can talk to your gynecologist about a prescription for a vaginal estrogen, which can be quite helpful. So a lot of people have the question of if we're trying to avoid estrogen in women who have breast cancer, why would this form of estrogen be okay? And that's a reasonable question. But there's a reasonable amount of research in this area. And it appears that vaginal estrogen is okay because it's a local treatment. So some estrogen does get into the bloodstream, but most just stays right in the vagina. And the amount that it gets absorbed into the blood appears to be much lower than what you get with hormone replacement therapy. Vaginal estrogens can be prescribed in several forms. They can come as a cream, a ring, or a tablet. All of these are placed directly in the vagina. A review of intravaginal estrogens over 19 randomized trials showed that all forms were equally effective. The creams appeared to have the highest rate of absorption into the bloodstream, and the ring appears to have the lowest. So if you wanted to minimize absorption of estrogen in the bloodstream as much as possible, a ring may be the best form of topical estrogen to try. A couple more questions. Let's see. Can I give some brand names for vaginal moisturizers to try? Unfortunately, I don't have the names of any of the vaginal moisturizers, but you can ask a pharmacist for a polycarbol-based vaginal moisturizer, because there are a variety that are available. The polycarbol-based seem to be the ones that help stabilize the maturation of the vaginal epithelial cells the most. And I wouldn't expect to see much of a difference across different brands. If one has more fragrance or something like that, I would avoid that. But otherwise, they should be equally effective. Then a question about pomegranate, coconut, and olive oils being effective. I have never seen any research on those, so I can't say. And then another question, if ER positive and PR positive are phytoestrogens okay? And how strict, the question is, if ER and PR positive are phytoestrogens okay? And how strict should we be on endocrine disruptors in skin and body care? These are really good questions. So the data on phytoestrogens is a little bit mixed. Historically, first of all, phytoestrogens are estrogens that come from typically a plant-based diet. So things like soy products, soybeans have high levels of phytoestrogens. So little chemicals that resemble estrogen but are plant-derived. So people like I was saying, for some period of time thought that you should avoid phytoestrogens in your diet. That has gone by the wayside. It seemed like a theoretical concern that no one was ever actually able to prove in actual clinical practice. And soy tofu provides a good source in your diet of very lean protein and plant-based protein. So it's no longer a recommendation to avoid that. And then how strict should we be on endocrine disruptors in skin and body care? This is a question that I even personally struggle with because there's not that much research on skin and body care products. They're not regulated by the same guidelines or regulations as medications. And so what is actually in some skin and body care products and how much that may or may not disrupt endocrine signaling processes is unknown. And so I personally try to minimize use of different chemicals for skin and body care, but that's not an evidence-based answer. It's just saying we don't really know, and kind of how do you personally feel about hedging your bets on that? And then another question, can having intercourse elevate your hormone levels? I don't know if it's fortunate or unfortunate, but the answer is no. Your ovaries will produce the same amount of estrogen and sex hormones over time, regardless of how much intercourse you do or don't have. So great question. The next kind of symptom that I brought up is weight gain. So for managing weight gain, I can recommend only the things that you've likely heard dozens of times. Keeping your weight stable over time means reducing calorie intake, eating healthy foods, and getting more exercise. We all know that is not as easy as it sounds. Maintaining a healthy weight after breast cancer, though, is important, particularly important for many reasons. So maintaining a healthy weight actually reduces your risk of breast cancer recurrence. It also reduces your risk of lymphedema. And staying at a healthy weight also helps your bones, heart, and blood vessels all stay healthy. If you or your loved ones have any reason to think that you have clinical depression, have a low threshold to ask your primary care doctor or oncologist to refer you to a mental health professional, such as a psychiatrist, a psychologist, a psychotherapist, or a counselor. Some cancer centers, many cancer centers actually, have mental health professionals that specialize in treating patients specifically who are dealing with cancer treatments. And sometimes that can be particularly helpful. Together, you can then assess your situation and discuss treatment options, which can be really beneficial. The same advice holds true if you're not depressed, but your mood changes are severe enough to interfere with the quality of your life. In the meantime, don't underestimate the power of lifestyle changes to help you start feeling better. Regular exercise is an absolute must for keeping stress levels down and for boosting your mood. In some patients, regular exercise has been shown to be equally effective to antidepressant medications. And then activities such as yoga, meditation, and again, training on relaxation and mindfulness can be extremely helpful. Someone asked, kind of poked again about the question about vaginal symptoms getting better or worse over time. So thank you for reminding me. Without treatment, vaginal symptoms actually get a little bit worse over time. The tissues of the vulva and the vagina become flattened and thin out. We say atrophied. And that without estrogen, eventually it will plateau, but will typically get a little bit worse over time. So if that is bothersome, I think, trying the lubricants during intercourse, the moisturizers, and then, being open to trying the vaginal estrogens are the things that will help. And then, with those treatments, the vaginal symptoms can be very well managed, but it kind of will take continued treatment. And your body doesn't really get to a point where that treatment's no longer required, unfortunately. Let's see. So we talked about the importance of monitoring bone health in women with breast cancer and how menopause and breast cancer treatments can leave you at higher risk of bone loss and osteopenia or osteoporosis. So when it comes to bone loss, prevention truly is your best defense. So whether testing shows that you have any evidence of bone loss or not, strategies that I'll mention here now can help keep your bones strong. So most women should get 1,200 milligrams of calcium a day through a combination of diet and supplements. Good sources of calcium include the obvious, the dairy products like milk, cheese, and yogurt, but also leafy green vegetables, almonds, and beans, I think are ones that we don't think of that have good amounts of calcium. And then you can also eat calcium-fortified foods such as fruit juices and cereals. Some of those will have calcium added, so just check the label and see how much has been added to those foods. If you smoke, you should quit. Weight-bearing exercises are also very important for women in maintaining bone strength. And then limiting alcohol use, because alcohol can also contribute to bone loss. If your bone density testing shows that you have worsening osteopenia or osteoporosis, your primary care physician or oncologist may recommend taking a bisphosphonate. A bisphosphonate is a medication that prevents your body from breaking down bones. Some common examples include Fosamax, Boniva, and Zometa or Reclast. And then other medications that may be used to treat osteoporosis in women who specifically have had breast cancer include Evista and Prolia, but those work through some different mechanisms. This is a great question. And I think helps to clarify this too. So when we are done with tamoxifen and or Lupron, will the vaginal symptoms get better? Will it eventually go back to how it was before? And this person volunteered the information that they started hormone therapy at 32 and have been on it for 7 years. So the good news is, particularly at 32, the answer is yes. Your symptoms will get better and you'll go back to how you were before. The little caveat on that is, so for some women, while they're getting their breast cancer treatment, they enter into menopause. And then, of course, your normal estrogen levels don't come back after you stop treatment. You're then postmenopausal. And then your vaginal symptoms would be similar to women who go through menopause separately from the process of breast cancer treatment. But when you're so young, it's very likely that your menstrual periods will return and all of those symptoms should go away. Another person asked, if vaginal symptoms get worse over time, does that mean that skin dryness and wrinkles also get worse as a result of AI on top of what happens with age? So that's a great question. That is something that's more hard to quantify for like a research trial or something like that. I can only speculate. This is not based on a randomized trial where women were, evaluated for how dry or wrinkled their skin was. But similarly, you should reach, over the first months of taking an AI, reach kind of a plateau where it's not continuing to get worse and worse. But your body just becomes used to this lower estrogen state, and it doesn't continue to worsen over time. Is alcohol, next question, are about, do alcohol and sugar increase estrogen? So alcohol and sugar do not have any interaction to increase estrogen. And the next question about this person said that they had an oophorectomy, so they had their ovaries removed during treatment, and I'm on an AI, an aromatase inhibitor. Any idea how long I should have hot flashes? Treatment at age 41, 2 years ago. That's a great question. And on average, the hot flashes should last for 1 to 2 years and should gradually get better with time. But again, just as women have a huge variation in how badly they experience their hot flashes, there's also, some women are like really not bothered. Some women are like just cannot stand it. There's similar variation in how long they last. So you can kind of make some statements about what happens on average, but that's no guarantee that for you as an individual, hot flashes will be gone in 1 to 2 years, although they likely will be. This is another question, are most doing AI longer than 5 years? And any research on increased recurrence in patients who discontinue AI at 5 years versus those who continue? So that's an excellent question. And the data on extended anti-estrogen therapy, to provide a bit of brief background information for people who may not be taking anti-estrogen therapy, going back in time a few years, the recommendation was to take these medications for 5 years. And then there have been some more recent data suggesting that 10 years of anti-estrogen therapy is actually much more effective in preventing breast cancer recurrence. But to go through that trial data, I could spend probably another 20 minutes at least going through that. But to sort of briefly answer your question, it does seem that extending your use for 10 years gives you the best possibility of not experiencing a breast cancer recurrence. But again, is something that you should discuss with your oncologist to kind of weigh your personal breast cancer profile and your individual risks and benefits and how much benefit you'll get from the extended 5 years of therapy. We also talked about how estrogen has a protective effect in helping to prevent women from developing cardiovascular disease, and how menopause leads women to develop heart disease at the same rates as men by the time they're in their 80s. So the best way to keep your heart and blood vessels healthy is through lifestyle. There's no single medication or group of medications that can compare to healthy lifestyle for preventing cardiovascular disease. So again, if you smoke, get help to quit. Do whatever you can. Exercise regularly. Learn relaxation techniques such as meditation, deep breathing, or yoga. And then eat a diet with lots of vegetables and fiber. And try to minimize saturated fats, sodium, and sugar. And then finally, losing weight, if you need to, will really go a long way to helping protect your cardiovascular health. So I told you about how for women with breast cancer, menopause can significantly affect quality of life and long-term health. But I hope I've also left you with a message that there are many ways to manage symptoms and live more comfortably with menopause. Lifestyle changes are frequently just as important and effective as medications in helping you feel better and live well. Here I have a couple slides of references that I used to put this presentation together. And a lot of what I covered came from Dr. Lynn Wang, who has a nice perspective, I think, on this topic. And I thank you for your attention and participation today. You guys have amazing questions, very insightful. And I hope this has been helpful. And please let me know if there are any questions I can answer at this time. All right. Thank you all very much.